Welcome to Essential Neuroanatomy Review, Lesion Localization in Neurology, Consciousness. This is David Lee Gordon, Professor of Neurology. For Essential Neuroanatomy Review, the learning objective is to localize a lesion in the nervous system based on clinical presentation, that is to say, the history and examination. Consciousness has two components: wakefulness and awareness. Wakefulness is the state of arousal with potential to experience awareness and is associated with open eyes. It is supported by the brainstem, and specifically within the brainstem, the ascending reticular activating system, or ARAS. Awareness is perception of self and environment. It is dependent on wakefulness. One cannot be aware if one is not awake. And it is associated with visual pursuit or responses to command. And it is supported by the thalami and the frontoparietal cortex bilaterally. This slide shows a graph of wakefulness on the y-axis and awareness on the x-axis to show you that some conditions affect both equally, and most do, and others affect one more than the other. And along the line where they are equally affected, wakefulness and awareness, a healthy awake person is both awake and aware, whereas a comatose person is neither awake nor aware. And normal sleep runs along the spectrum of the two together, wakefulness and awareness equally affected. A person who's dreaming is a bit more aware but not awake, and a person who has the so-called unresponsive wakefulness syndrome, formerly known as a vegetative state, is awake but not aware. A sleepwalking person, likewise, is more awake and not aware. And folks with absence seizures and focal impaired awareness seizures are awake but not aware. Their eyes are open, and lay people may think that's normal consciousness, but the lack of awareness means they actually do not have normal consciousness. The minimally conscious state is a state we have discovered in recent years that can evolve from the unresponsive wakefulness syndrome, and those people are a little more aware than the unresponsive wakefulness folks, but they're awake, a little more aware, but do not have normal awareness. The locked-in syndrome person is basically a normal awake and aware person, but cannot move anything. Depressed consciousness is a syndrome of decreased wakefulness or awareness due to dysfunction of the ascending reticular activating system, or ARAS, through either direct brainstem dysfunction or maybe indirectly through the bicerebral dysfunction. Brainstem dysfunction affecting consciousness is almost always due to a focal lesion and results in abnormal eye movements. We'll explain why momentarily. Bicerebral dysfunction, on the other hand, which has many causes, most commonly toxic encephalopathy and metabolic encephalopathy, but other causes listed here: intracranial hypertension, acute concurrent bicerebral lesions, physiologic phenomena such as seizures, post-ictal state migraine, and hypotension, has normal eye movements. And again, we'll explain the reason for that momentarily. So consciousness depends on an intact brainstem and bicerebrum. The ascending reticular activating system is the consciousness center in the upper brainstem, the midbrain and upper pons, and also involves the hypothalamus and basal forebrain. It is innervated by the lateral hypothalamus, and it diffusely innervates and stimulates bilateral thalami and frontoparietal cortices. Its inhibition, the ARAS's inhibition, causes decreased consciousness by either brainstem dysfunction, which is usually due to a focal lesion, such as a structural lesion, such as a stroke or mass, or bicerebral dysfunction, which is usually due to diffuse or multifocal lesions within the cerebrum, which is most commonly physiologic in nature, such as a toxic or metabolic encephalopathy. So, and again, to remind you, the brainstem affects primarily wakefulness, and bicerebrum affects primarily awareness. The clinical key to differentiating whether or not depressed consciousness is due to a brainstem problem or bicerebral dysfunction are the eye movements. The dorsal upper brainstem contains both the ARAS and cranial nerves 3, 4, and 6, the nuclei to cranial nerves 3, 4, and 6. And those three cranial nerves control eye movements. Therefore, a structural lesion that affects ARAS is going to affect cranial nerves 3, 4, and 6, and thus will have eye movement abnormalities. Brainstem dysfunction leading to decreased consciousness will have abnormal eye movements, whereas bicerebral dysfunction causing depressed consciousness will have normal eye movements. There is a spectrum to decreased consciousness, and the best way to describe these is through the stimuli that elicit responses. And for effective communication, I urge you to document those responses rather than just using the medical terms, because sometimes people don't understand the medical terms and does not make for effective communication. So the normal person with normal consciousness, has the 3 A's: awake, alert, and attentive. A person who is at the bottom end of this with no decreased wakefulness and awareness completely is in coma. What that specifically means is no purposeful response to any stimulus, even a deep painful stimulus. Delirium is the next stage below normal. It only occurs with bicerebral dysfunction, however. It does not occur with the brainstem. It's more of an awareness issue than a wakefulness issue. And the patient will be inattentive with abnormal behavior. The lethargic or drowsy patient, we specifically mean, has purposeful response to speech or touch. They look sleepy, their eyes may be closed, but when you just call their name or make a loud noise or touch them, they will respond. They will somewhat open up their eyes and look around. The stuporous patient is the person who has the eyes closed, they're sleeping, as it were, not normally, and have purposeful response only to deep pain. If you talk to them, they do not respond. If you touch them, they do not respond. Even if you use a pinprick, they may not respond. But you rub hard on their chest wall, for example, the deep pain will make them aroused. That's called stupor. I think one way to think about this in your mind is to understand how ethanol or alcohol intoxication affects consciousness. It's a good example of a toxic encephalopathy that can lead to this entire spectrum. And before drinking, you have normal consciousness. You drink a little bit and you want to get so-called tipsy. Now, tipsy is delirium. That is a purposeful delirium to decrease your inhibitions, etc., etc. That's a delirium. You drink too much alcohol, you get lethargic or drowsy. You drink even more, you get stupor, and you drink even more, you can be comatose and even die from alcohol toxicity. So I think that's a good way to look at toxic encephalopathy, is alcohol. It is an intentional toxic encephalopathy. Going back to delirium, this is a syndrome of global cognitive dysfunction manifested by decreased consciousness, especially awareness more than wakefulness, inattention, and disorientation with normal language function, and possible abnormal behavior, agitation, or visual hallucinations. By the way, visual hallucinations are always neurologic, not psychiatric, by the way. Equivalent terms for delirium are acute confusional state and acute encephalopathy. Delirium tends to be acute to subacute in onset and is often transient, reversible, and fluctuating in severity because of the type of things that cause it. It is due to bicerebral dysfunction, as we discussed, the thalami or diffuse frontoparietal cortex involvement. And again, toxic or metabolic encephalopathy most commonly causes this problem, such as drugs, medications, toxins, serum chemistry abnormalities, systemic infection, or fever. Those are all examples of toxic or metabolic encephalopathies. Other possible causes include acute concurrent focal bicerebral lesions, meningeal irritation, seizure, postictal state, and even migraine. Once again, coma is lack of wakefulness and awareness even with external stimuli. In this case, both the brainstem and bicerebrum are not working, but one usually predominates. Now, one thing to remember is that coma never lasts forever. It lasts a few weeks at most, and if you see in the literature, in the lay literature, people have coma for 20 years and wake up, they're not using the term coma properly. Let's understand coma. Coma must evolve within a few weeks to one of three things. Either the patient wakes up becomes normal. Maybe they were just in coma because of a metabolic problem, and you fix the metabolic problem. They become normal. Or it evolves into unresponsive wakefulness syndrome. That is usually the situation when the problem is bicerebral, not brainstem. So someone, for example, with a drowning victim or hypoxic ischemic encephalopathy, or severe watershed strokes. So they comatose initially, and as they recover, the brainstem's working, but the bicerebrum's not. They get into this unresponsive wakefulness syndrome, formerly known as vegetative state. And the third possibility is obviously death, either cardiopulmonary or brain death. When people say they have a patient who woke up after 20 years of coma, they were not in coma. They were in unresponsive wakefulness syndrome during that time and mistakenly called coma. And if that progresses to that minimally conscious state where you're subtly improved, that is what they mean by waking up from a coma. You're not really waking up from a coma. You're waking up from unresponsive wakefulness to this minimally conscious state. On exam, a patient who has coma, you must first establish that there is coma. So the eyes are closed with no meaningful response to any stimulus, voice, touch, pain of any kind, superficial or deep. And then you must determine why. Brainstem versus bicerebrum. And you look at eye movements as the most important, but also other brainstem reflexes, such as gag and cough reflexes, pupillary responses, corneal reflex. And then you want to look for posturing, both decorticate and decerebrate, which we will discuss later. Corneal reflex, respiratory pattern as well. The etiology of the coma largely determines prognosis. Once again, if it's a metabolic problem, you correct the metabolic problem, the patient can wake up. If it's a severe structural problem or severe bilateral strokes, for example, it may be not as likely a positive prognosis. There are two chronic bicerebral dysfunction syndromes that present with profound awareness deficits: the unresponsive wakefulness syndrome and the minimally conscious state. The unresponsive wakefulness syndrome, formerly known as the vegetative state, is a clinical condition of complete unawareness of self and environment, accompanied by sleep-wake cycles with complete or partial preservation of hypothalamic and brainstem autonomic function. It is due to bicerebral injury that is severe and usually irreversible, although rarely can improve to the minimally conscious state. The unresponsive wakefulness syndrome is usually a sequela of coma. There's normal breathing, and the patient is awake but unaware. They have intact brainstem reflexes but cannot feel pain. Relatives must be involved in the decision to withdraw care per the American legal system and healthcare system. The decision to allow to die, also known as comfort care only, is based on personal, cultural, economic, and medical issues. The minimally conscious state is slightly improved from the unresponsive wakefulness syndrome, in which the patient has fluctuating awareness with appropriate responses to some stimuli and can feel pain. It nearly almost always occurs as a sequela of unresponsive wakefulness syndrome. Brain death is a term we use to mean essentially brain stem death. This is irreversible cessation of all functions of the entire brain, including the brain stem. It is due to profound, irreversible brain stem injury, and there are three essential exam components to establish the diagnosis: apnea, coma, and absent brainstem reflexes. If one realizes that apnea is one of the criteria, one should realize that this only has been occurring or being able to be diagnosed in the era of ventilators. Before we had ventilators, there was no such thing as brain death. People stopped breathing and they died, a cardiopulmonary death. Now that we have ventilators, we have found that some people on the ventilator have no spontaneous respirations, but we keep them alive with the ventilator, but they are in coma and they have absent brainstem reflexes. Now, to diagnose brainstem death, you have to have persistent apnea, you have to have coma with a known cause, and you have to have absent brainstem reflexes. And there are other specific criteria we won't get into on this slide. In American law, relatives are not involved in decision to withdraw care. Brain death determination is a clinical decision by the physician. And by law, the Uniform Determination of Death Act of 1981 determined that brain death is equivalent to cardiopulmonary death. Thank you for viewing and listening to this presentation. This is a DLG Insight production, innovative neuroscience ideas and thoughts on education.